This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. We are still here. I know you all haven't heard from us in a while. It's been busy, but let's just do our regular intro, then I'll tell you what's going on. For those of you who are new, I am a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since 2016. Which is going on 6 years, going on 7 at this point. We're talking about pediatric hospital medicine, continuing medical education topics. This is no different and no exception today. We have a very exciting one. Just a quick reminder that free CME is available courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. So feel free to reach out and get it just by clicking on the link at the bottom of the podcast description. Now, everyone has heard about this in the news, and finally we're talking about something that's a virus that's not COVID, which I know is very exciting to everybody. So first, a little of what we've been doing, why it's been so long since you've heard from us. As you all know, University of Pittsburgh, Children's Hospital of Pittsburgh has a Pediatric Hospital Medicine Fellowship. We had our first ACGME site visit, which if you don't know what that is, good for you. I do now, and we did a nice job with it, but it took up a fair bit of our time. But now, we are here. We have a number of episodes planned. You're going to be hearing from us a lot. So first, let's talk about our topic today. You've seen it in the news. You've seen it on whatever feed you use to read about whatever's going on in the world. This is the severe hepatitis that started in the UK. I believe we're going to find out more in a bit. Worked its way over to Alabama, and we're seeing it more and more. And the thought is this is adenovirus induced, but we're going to see how true that is or not. We have 2 expert guests with us today who were kind enough to give us their time. I will introduce them, and then we will begin having this conversation about this topic. Our first guest is a friend of the podcast, but we haven't seen him in 6 years. He has been here. It's Dr. Michael Green. Dr. Green is a professor of pediatric surgery and clinical and translational science at the University of Pittsburgh School of Medicine. He received his medical degree from the University of Illinois in Chicago and his master's degree from the University of Pittsburgh in Pennsylvania. He completed pediatric residency and a fellowship in pediatric infectious disease at Children's Hospital of Pittsburgh. Throughout his career, Dr. Green's clinical and research interests have focused on the prevention and treatment of infections in immunocompromised children, with a particular focus on children undergoing liver transplantation. Now you know why we asked him. Dr. Green has published more than 170 peer-reviewed articles and has written more than 80 review articles or textbook chapters. He serves as the associate editor for the Pediatric Transplantation, the American Journal of Transplantation, and the Journal of Pediatric Infectious Disease Society. He was also co-editor of the first edition and more recently editor-in-chief of the 4th edition of the Guidelines for the Prevention and Management of Infectious Complications of Solid Organ Transplantation, published by the American Society of Transplantation. He has participated on numerous consensus conferences and guideline working groups relating to the field of transplant infectious disease and is a past chair of the IPTA ID Care Committee and the Optin UNOS Ad Hoc Disease Transmission Advisory Committee. An active teacher and clinical researcher, Dr. Green has consistently received grant funding for his work since 1987. So Dr. Green, thank you for joining us.
My pleasure, Tony. Thanks for having me.
Our second guest is new to the podcast, and we appreciate him coming on, Dr. James E. Squires. Dr. Squires earned his medical degree from the University of Texas and went on to complete his training in general pediatrics at the Cincinnati Children's Hospital Medicine Center. Following residency, he completed a fellowship in both pediatric gastroenterology and pediatric advanced transplant hepatology at CCHMC, and completed a master's in clinical and translational research at the University of Cincinnati. Following completion of his training, Dr. Squires joined the faculty at the Children's Hospital of Pittsburgh in 2015, where he's currently an associate professor in pediatrics, the director of the Pediatric Advanced Transplant Hepatology Fellowship, and Associate Medical Director of Hepatology. Dr. Squires remains active in both clinical and research pursuits. He's a co-investigator on the Children's Liver Disease Research Network and an NIH-funded consortium working to improve the lives of children with rare cholestatic liver diseases. He's a member of the Society of Pediatric Liver Transplant, a multifaceted organization focusing on improving outcomes for children receiving liver transplantation, and the clinical lead for the Starzl Network for Excellence in Liver Transplantation, a novel learning health network of leading pediatric transplant institutions. Other interests include acute liver failure, and Dr. Squires is currently the site principal investigator for the NIH-funded TRIUMPH study, assessing the safety and efficacy of immune modulation in PALF. So, Dr. Squires, thank you for joining us.
Tony, it's a pleasure.
Now, let's do our conflict of interest statements, gentlemen, and so we'll get that out of the way. I will go first. Mike, I'll kick it out to you. Then Jim, I kick it out to you. I have nothing to disclose.
So I am a consultant for 3 organizations, essentially 2 of them are DSMBs. That is for Alovir and ITB Med. And then I'm on an adjudication committee I'm on an adjudication committee for Alovir. And the third DSMB is for Bristol Myers Squibb.
I have no disclosures.
Now, we're going to start with getting some background information because my suspicion is a lot of our guests have COVID fatigue, our pediatric hospitalists, and may have not read as much as they would have liked to about this severe hepatitis unless they've seen it. So, Jim, would you mind? All I know is also what's on the headlines because I have COVID fatigue too. And when I saw another virus causing terrible symptoms, I said, "Oh my God, I don't know that I can deal with this right now." So can you catch us up? What's been going on? Where are we?
Yeah, no problem, Tony. And I would caution that we are in the early stages, right? I mean, I think what you may hear us say repeatedly on this podcast is more to come, more to learn. But where we are and where this started, particularly in the United States, was an outbreak back in October through February in Alabama. There were actually 9 children who presented with this severe acute hepatitis, initially of unknown etiology. And when we say unknown etiology, there's generally a battery of tests that these kids probably underwent looking for some metabolic, some autoimmune, some genetic reasons why kids have acute liver failure or acute hepatitis. We don't have all the data on that, but we were told that an etiology wasn't found. 2 of these children received liver transplants, and the others recovered. But because of this kind of outbreak, clinicians there were very astute. They alerted the CDC that they were seeing this kind of signal on the ground. And subsequently, there have been investigations into potential etiologies that has uncovered an association possibly for adenovirus as a potential cause. And again, we'll talk more about where the adenovirus was seen and how strong of an association this was. Subsequently, both in Europe and in the United States, there have been ongoing efforts to try to identify whether or not this is something that is being seen more broadly. So in Europe, there was a small outbreak noted up in Wales of a handful of kids, and in the UK, up to 111 cases have been identified as of last week. More broadly in Europe, 95 cases have been identified. Here in the United States, the CDC has asked us to report cases of this severe acute hepatitis. And I think what is coming out in the lay press is numbers somewhere around 100 patients have been identified. I've actually been talking with the CDC about this because I still think it's important to recognize that there's some unclarity as what is being defined as a positive case. I think what they have been asked us to report to them is a very low bar. It's any child who has a ALT greater than 500 and no other known cause. And I think that is a pretty low bar to count as a collection case. How they are taking that information and confirming a case, I still think is evolving. And so I think this is where, again, there's going to be more to learn as to exactly how many of these cases are out there.
This is a good point to piggyback on a question we were going to ask later, but you brought up the low bar, and we keep reading severe hepatitis. Can you talk to us a little, Jim, about why this is a low bar and what makes a case severe versus mild versus moderate hepatitis What's the definitions?
No definitions, right? I think we got to be clear about that. We have not, from a pediatric liver standpoint, defined what severe, moderate, and mild would be. I think, if you would ask me what my working definitions are, I would say probably 500 would be in the moderate to severe, maybe hepatitis block. Maybe below 250 or 200 would be mild. Clearly, 1,000 or above would be severe. I know there's a lot of overlap there, and I'm being ambiguous on purpose because, again, I think there aren't any clear definitions. And so, and I think when we talk about hepatitis, and again, this is a point that I want to hammer home from a liver standpoint, hepatitis just tells us that there is liver inflammation, and I think while that is critically important, I think probably as important, if not maybe more so, is how the liver is actually functioning, because you don't get transplants for hepatitis. You get transplants for liver failure and liver dysfunction. And those are markers that include things like INR and other markers that will need to be assessed in these kids in order to determine that. And so, right now, I think the CDC is really wanting as many cases or many of the cases so that they are able to truly identify whether or not this is a true signal or not. But I think that an ALT of 500 in isolation, there's likely a fair number of those kids that are out there. They're going to end up being reported to the CDC, and likely not all of them will be a true case. So
is it fair to say, and correct me if I'm wrong, if you had a Tylenol intoxication, you could have an AST and ALT of 500? There could be numerous causes for that kind of a thing.
Absolutely, right? I mean, Tylenol is a great example. If you have a Tylenol ingestion, you're definitely going to have an ALT over 500, right? I mean, the classic acute APAP toxicity, those kids come in with ALT, ASTs in the thousands often. And so, I think even in the setting of other kind of acute infections, whether it's mono, whether it's, some other, kind of acute illness, ALT elevations of 500, may be commonly seen in the setting of other systemic infectious diseases and are in of themselves not necessarily that doesn't portend that the liver is going to have one of these severe outcomes that we've seen in some of these reported cases.
So the CDC has a broad definition because they want to collect everyone to see which of these cases are actually part of the severe hepatitis. We think from adeno, but we're not sure. Has there been reported morbidity or mortality from these?
So, there have been reports in the lay press. So I think there was a report last week from CNN about 5 deaths that have been reported. Obviously, the 2 patients from Alabama, 2 of them went on to receive transplant, which is obviously a very severe outcome. And so I think there was a case, I think, in the press of a child in Minnesota that I read the other day. So I think there are these reports that are coming out. I think that I have not seen specific numbers from the CDC as it relates to mortality, but I think that there do seem to be some cases that are being reported.
So, Mike, can you walk us through one of my first questions is, did the adenovirus connection surprise you? Has there ever been a history of adenovirus doing this kind of thing? And then how strong is that connection between adenovirus and this severe hepatitis?
So a couple of comments. So, adenovirus is really a very common community-acquired viral pathogen. And if you look at kids less than 6 years of age, this is the peak age group where you'll see children get infected. And depending upon which strain of adenovirus they get, and the nomenclature is a little confusing because there's both numeric adenovirus, so adenovirus 2, adenovirus 41, but then there's also an alphabetical adenovirus where they maybe call it adenovirus group A or adenovirus group B or group C. Some adenoviruses are known to cause upper respiratory tract infection with some frequency, and others are known to be associated with diarrheal illnesses. And in particular, this adenovirus 41, which has a little bit of attention, I think from the Alabama cases, is known to be more of a GI virus although respiratory symptoms can be seen with it as well. Adenovirus has also been associated with important infection in settings like military barracks, where you have young military recruits, presumably who are not fully immune protected because they haven't seen a strain. And then in the close quarters of a barracks, it can easily spread. It's an important cause of conjunctivitis as well. Now, we do see adenovirus hepatitis, but it's not that common in those who have a normal immune system. At one point in liver transplantation, we saw as many as 20% of our liver recipients and kids would develop adenovirus infection, half of which would have a very important adenovirus disease, many of which had hepatitis, some of which succumbed to that virus. So in the immune compromised setting, we have seen adenovirus hepatitis before, and there are particular serotypes like adenovirus 2, adenovirus 5, historically that had been more associated with hepatitis than others. The adenovirus 41 is one that has been thought to be mostly limited to the GI tract, and it's not something that I believe that people have thought about as causing hepatitis previously. And I do want to bring up a point here, and then I would like Jim to comment on it as well, is that although I think 9 of the patients from the Alabama cohort of patients, when tested in either stool or blood, were found to have adenovirus, in none of those cases, when they did liver biopsy, including those that had liver transplants, so they had access to the entire liver that was resected, did they find actual evidence of adenovirus in the liver. They looked for it by looking for a cytopathic effect, that is, looking for an adenovirus-specific inclusion. They did molecular studies looking for staining for adenovirus against an immunofluorescent probe, and they've also did PCR looking for adenovirus, and they did not find the adenovirus in the liver itself. And so while the association is there that adenovirus was found, at least in that subset of patients that are being grouped together as they explore this, now international cohort of possible patients, they did not find it in the tissue that matters most here, in the liver. So I don't know that we have an understanding if this is from adenovirus, if it's an event that happens after adenovirus, so a post-infectious sequelae, or if it is completely unrelated to the fact that they had adenovirus in their blood and maybe something else was perturbing their immune system and distracting, allowing adenovirus that might have been latent in their GI tract to have an increased likelihood of getting into the blood. And in fact, in some of the Alabama cases, they looked for EBV. All of them were seropositive. That is, they had anti-EBNA antibody, so remote infection, and found Epstein-Barr virus in low levels in their blood, which was attributed to sort of a reactivation. And adenovirus is probably a latent virus of sorts in the GI tract, so that kind of reactivation might be an alternative explanation. And I think it would be interesting to hear Jim's thoughts on this as well.
I mean, I think I would mirror those thoughts, right? I mean, I think not being able to definitively identify adenovirus in any of these livers, and I don't think it was just the Alabama cases. I think it's been in any livers in any case worldwide, as far as I know. Again, there may be data that's been collected that I'm not privy to yet, but in speaking with colleagues, from England and other places who are dealing with this as well, they have not found adenovirus specifically in the tissue. And so I think we need to be careful to draw clear connections between the presence of adenovirus in the blood, which we have never really looked for in children who present with these types of presentations, and this current outbreak.
And I'll just add 2 things to that. One is that in certain populations, we do look for adenovirus in the blood, for instance, in children that undergo bone marrow transplant. And we often find it there, sometimes at high level, and not always with any symptoms. And the other point I'll make is that I personally have seen adenovirus hepatitis in transplant recipients, liver transplant recipients, and there was no problem finding the inclusions or recovering the virus by molecular techniques and even culture in the old days. from those that had evidence of adenovirus hepatitis. And so I think the possibility that this is either not related or is a post-infectious inflammatory response needs to be kept at the center of our thinking.
Mike, that's immensely helpful that you've seen it in when liver transplant patients get hepatitis due to adenovirus. There's been no trouble getting it out of the livers. Jim, can I ask, it would seem to me if adenovirus isn't a typical thing you would look for severe hepatitis, it means it's not a very common cause of it. And up until recently, you had no reason to look for it. Is that a fair assessment to make?
I mean, again, ignorance is bliss, right? If we haven't looked, I don't know if, maybe we should have been looking all this time. So I don't want to be so bullish as to say that it is not. I will say that, as Mike notes, and he makes an excellent point, we definitely see this in immunocompromised populations where it is in the liver and you see it in the liver. As it relates to a virus triggering some additional hyperinflammatory response in the liver, that is the whole premise of an ongoing NIH-funded clinical trial that you mentioned, the TRIUMPH study. Kids, and now I'm going to kind of shift a little bit, right? But kids who meet the clinical definition of acute liver failure, who oftentimes do have liver enzyme elevations associated with that, and oftentimes have had liver enzyme elevations prior to meeting criteria for acute liver failure. About a third of the kids who come in with acute liver failure, we never identify a cause for. And in many of those kids, there is suggestion of hyperinflammation and an overactive immune system. And there has always been a hypothesis that there was some sort of a trigger, an infectious trigger. The classic story of the prodromal phase 2-3 weeks back where something ran through the house and everybody had fevers. This kid had fever for the past several days, not feeling well, suddenly turns jaundiced and is in the hospital with acute liver failure. That story is typical for those kids. And so whether or not this will help us understand that more, I think is of intense interest to us who have seen the kids who go on to progress to liver failure. And so I think that, it's something that we hope we'll be able to know a little bit more about once the CDC and everybody gets more data out to us.
How, I guess that's one of my questions, is how rapidly is data getting out? Is this something that we'll be knowing a lot more by midsummer, late summer, or does it depend on how widely? Because the COVID, we have experience with this with COVID, but COVID was everywhere. There was a lot of data. This is not as prevalent, thankfully. So what's your expectations? We'll start with Mike and then Jim in terms of how quickly you expect to hear and see more stuff.
So, in terms of data, and Jim could maybe speak to this more, but I've now begun to see descriptions emerging as people are trying to say, what is the baseline of pediatric acute liver failure, or the baseline frequency that you see patients that would meet defined criteria to be included in this syndrome? And it's not really well established in the literature to even know where we start from 2 or 3 years ago to sort of know what's elevated. And so you're really trying to get that background epidemiologic information, although there's some data and there have been NIH-funded studies looking at pediatric acute liver failure that Children's has participated for a long time. And in fact, Jim's father, Rob, was the principal investigator of an NIH-funded study on that topic a number of years ago. But I think, to get the information, there is coordinated or at least parallel efforts in a lot of countries, some effort by World Health Organization to try to coordinate this, but it's probably clearly distracted also by still managing the pandemic. And then to try to identify what are true cases and to have access to the kinds of studies that one might want to do to answer the questions. So I know that, in one effort to get at the true association with adenovirus, and I use still the word association, that the CDC is now making recommendations that if you evaluate one of these patients, that you should try to look for adenovirus. And they'll suggest that you do PCR literally of whole blood, so not plasma, but whole blood, because they think that's more sensitive. They suggest that you try to get stool for adenovirus. And then if you do a respiratory viral panel or RVP to look for adenovirus as well, to try to see at least if these patients are positive or not. Again, again, this establishes an association. It does not establish causality. And then I think, the further work of immunologic studies and trying to understand it may go faster or slower depending upon what these epidemiologic studies show and what science can be offered to try to answer these questions. And there are a lot of working groups that are now beginning to refocus their attention, or new working groups that the CDC is organizing in the United States to try to get to this. Short answer is, I would be shocked if you had answers in just a few months. I would be not surprised if you have relatively advanced hypothesis and maybe explanations in a 6 to 24 month period of time, depending how lucky we are.
I mean, I would only add that, acute liver failure, again, is different than acute hepatitis. We have a lot of data about that. And I think one of the questions that a lot of at least the hepatologists are asking ourselves is this really an increased incidence of that, right? I think we've never known what the incidence of children who present with ALTs of 500 is, because it is relatively common, and I think most of those children go on to improve with supportive care and spontaneously. They don't get the $1 million workup because you get out of the way while they get better. And those that progress to liver failure, we have quite a bit of data on. So I think one of the things that I actually think we will have relatively soon is to know, as they're collecting all of this information about, kids with ALTs of 500, is how many of those kids actually go on to develop liver failure and more severe symptoms that may require more severe intervention than the kids who kind of get better on their own. So I agree with Mike that I think it's going to take some time to get the mechanistic studies, the viral studies, and some of the hypotheses that are being generated now to work those out in the system. But I'm hopeful that we'll get a sense relatively soon as to whether or not this is actually a signal that we're seeing that kids are getting this syndrome and progressing to liver transplant or not.
Now, Mike said something, Jim, that I'd love for you to comment on. We have a lot of pediatric hospitals that listen to our program, and healthcare professionals will take care of kids in the hospital. Can you walk us through what the typical presentations are, or just in general, when you have acute severe hepatitis, we don't have a way to quantify that, what should a pediatric hospitalist, who are likely going to be the first line besides the emergency room, who see this kid? And then when you're doing that, please keep in mind, we have community pediatric hospitals who are listening who may not have access to a friendly neighborhood hepatologist to help them out.
Well, for those who don't have access to a friendly neighborhood hepatologist, you're welcome to take my number and call me anytime. So I'll start there. I would say that, first point is I'm actually, me and several colleagues from our pediatric GI and liver associations are working with the CDC actually to hopefully in the next days put out a guidance document that will be on the CDC website that can be used by frontline healthcare workers to suggest, a reasonable approach to these kids. Obviously, it's not going to be guidelines. It's not going to be evidence-based, but I think something that's been, put through the ringer of several hepatologists who are thinking about this. What I would say is, the first question is, who to test, because the initial symptoms that have been reported in these cases, and that, again, that we've seen in our clinical experience, it's all non-specific stuff. It's fever, it's fatigue, it's, loss of appetite, belly pain, nausea, vomiting, very non-specific symptoms. I think the good news is that the diagnosis of this is relatively simple. I think, relatively easily accessible blood tests, ALT, AST, bilirubin, those are going to allow you to pick up these children. And so although, maybe the presentation is going to be nonspecific, at least the tests should be readily available to most practitioners who are out there. I come back to this fact of I do think it's going to be critically important if you have a child that you're looking for this syndrome or this disorder in, that you also send off some functional studies looking at the INR and the prothrombin time, because I think that's going to be critically important to understand, where the child may be from a function standpoint. I think most importantly, probably from that standpoint, obviously, if you do blood work and the ALT is 2,500 and the INR is 1.8, that's easy. That kid needs to likely be seen by a subspecialist and potentially evaluated in the hospital. I think for those children who have ALTs of 200, ALTs of 300, INR is stable. What we know about this disorder or this syndrome from an acute liver failure standpoint is that trajectory is key. and where these numbers trend over time is going to be incredibly informative. And so if you have a child that's symptomatic, that has some elevations in the ALT, the AST, or the bilirubin, I think, what we're going to likely put out in the document is probably repeating those blood tests in a, 3 to 5 day range is probably reasonable. Clearly, if the child is sick or the family's calling or there's decompensation, you adjust that. But following up with these, kind of, again, relatively accessible blood tests to see what the trajectory, specifically looking at the bilirubin and the INR, right? Those are the two that in the acute liver failure study have shown to have a good prognostic value as to where this child may be heading. ALT, AST, not as much, but I still think is going to be important. I think the other kind of clinical manifestation that we watch for that is challenging, particularly in this age group, is the development of a complication like encephalopathy. Many of these children that have been reported with this syndrome are in the very young age to toddler range, less than 10. Most of them, some of them down into less than a year. And so encephalopathy in a 6-month-old is going to be challenging. They're probably can appear encephalopathic during nap time. But I think that, counseling families that, changes in their sleepiness, their behavior is also going to be something that may at least prompt a phone call to the clinicians in order to kind of stay on a radar. So short answer to your question is, I think repeating tests that are abnormal, looking for the trajectory, specifically the bilirubin and the INR, and any change in clinical status from a altered mental status standpoint are going to be the big things that we're going to want to watch for.
So in the hospital, we're going to be getting AST, ALT, probably bilirubin, and likely PT, PT, INR daily. So you would, I'm assuming, then suggest we keep the child until we for sure see a downtrend. So we're not sending somebody out who's clinically getting worse. And then looking for encephalopathy. If, of course, we see that as one of the end stage effects, that child should be, if they're in a community hospital or somewhere without an ICU or a GI specialist who can help, perhaps transfer at that point. Otherwise, get everybody involved, GI, hepatology, depending upon where you are, to help with those kids. Does that sound fair?
I think so, right? I mean, I think confirming stability is going to be key here. I think, for those children who did require transplant, who did have liver failure associated with their syndrome, we know that this is a very dynamic process that can turn on a dime. And so we have to be diligent in how we monitor for these kids. Absolutely, if this is a patient who is not at a transplant center, if you're seeing the bilirubin and the INR rising, particularly if it reaches a threshold, we have classically used a threshold of 2. We recognize that that's just a number, and was a number determined to identify patients who would be enrolled in a study that were at risk for transplant. That being said, an INR of 2 should absolutely be a child that should probably be in close consultation with, if not physically at, a transplant center that can trigger that if it's needing, if the patient's going downhill. So those are things that I would definitely be watching for.
All right. Well, one of my questions was going to be, because of this association with adenovirus, what can we do to prevent in terms of hand washing? In the era of COVID, we're all used to masking at this point. But what you guys have told me is it's an association. We're not really sure it's there. We haven't found it in any of the livers. So at this point, is there any guidance when parents ask us what can they do when they read about this on any of the news channels? Mike, I'll start with you.
Well, if you look at the cases from Alabama, they not only tested positive for adenovirus and a couple for EBV, but a number of them also had other community-acquired respiratory viruses. So there was rhinovirus or enterovirus, the metapneumovirus was in one, RSV was in one, human coronavirus, not COVID, was in one. And so, there may be a viral trigger, even not adenovirus. I think that it always makes sense that if your child is sick, it's probably a good idea to limit their going to daycare or other child care facilities until they're well. Masking helps, but we've given up masking to a large extent outside of the healthcare setting in the community. So there's not a lot of masking necessarily going on. Washing your hands makes a good idea. Adenovirus, if it is adenovirus 41 that turns out to be involved, is an enteric adenovirus, which means that if the children are toileting themselves, as they, that you really want to reinforce they're washing their hands. And of course, if we're toileting them, that is, we're changing their diapers or what have you, we want to be careful and wash our hands, especially because if we have several young children at home, we might do a similar thing for more than one, and we could spread it from one child to another, or we could prepare food for our family after we just change diapers. And I know we all think we wash our hands, but we don't always wash them as well as we could. So, good basic hygiene is a good way to mitigate and limit spread of community-acquired viruses. And if this is due to adenovirus or other community-acquired viruses, doing those things may help, certainly can't hurt, and probably worthwhile to do. But we have no vaccine for adenovirus. We have no proven therapy for adenovirus. There are drugs that are used. You'll see that Cidofovir was used on some of the patients from the Alabama series. But I will tell you, there's no convincing evidence that adenovirus is treated effectively by Cidofovir. And if it is, it might be that some strains of adenovirus respond while other strains are inherently resistant. And we just don't know the answers to that question.
So if I'm going to summarize this correctly, I'm going to say this is an outbreak of severe hepatitis. Some cases have led to liver transplant. Reportedly in the news media, some have led to death. That has not been verified by the CDC. There's an association with adenovirus, but there's not a correlation because we haven't seen it in any of the livers. And you can see adenovirus when it causes liver failure in transplant patients. So we know it can be there. At this point, more information is coming out. If you're a pediatric hospitalist taking care of these patients and you see an increasing AST and ALT, get bilirubin, get functional markers like PT, PTT, INR. If your Billy's 2 or above, that really consider getting help from a hepatologist, GI specialist, or if you're at a facility without those things, transferring, or if the patient clinically decompensates on you and has anything like encephalopathy. Jim, is that a fair summary?
Yeah, I think you mentioned bilirubin greater than 2. I think probably you meant INR greater than 2 should prompt the referral. But again, I think an increasing bilirubin is definitely something to watch out for as well. And independent of the INR going up, should trigger caution. But absolutely, the INR of 2 has been a cutoff that they should be in contact with, if not at a transplant center.
And I would just add that if you're taking care of one of these patients, you need to report these cases, right? The CDC is interested in having patients that are under 10 and under who have this, the elevated enzymes, I think in the absence of a proven alternate explanation. And the other thing is, because they're asking to identify the potential association with adenovirus, if you're seeing such a patient, go ahead and order the test. And so they want a whole blood PCR for adenovirus. And if your lab doesn't do it, there are send-out labs that will definitely do it. They want stool for adenovirus. And same thing, if your lab doesn't do it, there are send-out labs that you can. And then they wanted an RVP, and I think most hospitals have access to an RVP or their send-out labs. And amongst the panel of all the different viruses, adenovirus is included in almost all RVPs. So I think it's important that if you're seeing these cases, so that we can learn and understand whether this is in fact an event or whether this is just scattered noise getting a lot of attention, we need to sort of track these cases. And all of us that care for kids that might meet these criteria should make an effort to make sure the cases are submitted to the CDC.
Mike, that brings up a question. Now, here at Children's Hospital of Pittsburgh, there are people who do this, so I've never had to do it. But if I'm a hospitalist taking care of this patient somewhere without all the resources we have, can I call the CDC and they'll remind me of this and tell me what to send, or how does that work?
So I think it's more at the state Department of Health level, and perhaps if you have a county health department. I know that in the state of Pennsylvania that our PA Department of Health is actively involved with this. They actually were reaching out to individuals at all the hospitals that they could recognize that cared for pediatric patients. They were actually suggesting that they would be happy to complete the relatively long case report form as long as we gave them access to the medical record. And they were fine with like a printed or disc version of the medical record for the given patients with a small amount of information to sort of lead them as they then went through the process. So I think if you reach out to your Department of Health at your county or state level, they can give you guidance. I'm sure if you called the CDC and asked for guidance, they would give you a little bit. And in Pennsylvania, there was a health alert that was sent out that included the recommendations from CDC. And many of our colleagues across the country probably have had similar alerts sent to them by their state departments of health.
Well, this is great. And then we'll look for the what Jim is working on with the CDC in terms of guidance for frontline workers. This is where I usually say, I don't have any more questions. Is there anything I should have asked that we didn't talk about? We'll go Jim, then Mike.
Nothing else that I think you should talk about. But again, I don't know if it is possible to put my contact information or our contact information onto this podcast. We definitely want to be as readily available to the community as we can be. And so in addition to contacting the CDC, we would be happy to help wherever we can, either by phone conversation or email or other ways of communication to make sure that you guys on the front lines are comfortable caring for and managing these patients. And when you're not, making sure that we're able to bring them to a place where we can provide some of that comfort. So I don't know, Tony, if I'm happy to just say my email or if we can post it somewhere, what's best?
Well, Jim, this goes out to all over the world. We have people downloading us everywhere. If you're comfortable, I'll put it on, but you may get calls from anywhere.
Oh, that's fine. Put it on, right? I think that'd be great. I didn't know you were so popular, but congratulations on that. That's fantastic. And like I said, we want to help. So please feel free to share my contact information with everybody that's listening.
And I think that from my perspective, Tony, I think that the conversation has really covered the breadth and depth of where we're at right now. Again, I worry that too much has been attributed to adenovirus when it's not been found in the liver. And I shared, that I know a basic science adenovirologist that's working with the CDC, and to the evidence that she's seen so far, she's skeptical, at least of a direct effect, which I am as well. And I think Jim is as well, because we're not seeing inclusions or adenovirus recovered from the liver. And, the problem with making the assumption that it's adenovirus is that you will soon see people trying cidofovir, as they did in two of the cases from Alabama when I think they got the cidofovir when they got shifted to the transplant center, as opposed, and maybe they got them at Alabama itself. And cidofovir is not a medicine that comes without side effects. It definitely is nephrotoxic and other side effects there. So I think, we've accomplished the goal of raising some doubt and uncertainty as to what the exact role is, and raising the possibility of post-infectious, which it may be. And so I think that from my perspective, we've gotten where we probably need to be at this time, recognizing that we might say completely different things 4 weeks from now or 4 months from now.
And if things change, can I bring you guys both on? We'll talk about the updates on where we are.
Yeah, I was going to say absolutely, right? I mean, I think this is going to change. There is going to be more information. And so would be happy to join back, as information evolves and comes out, in order to bring hopefully some more clarity to this particular issue.
And I would be happy to join as well, Tony.
Okay. Thank you both very much for your time. This has been a great conversation. I really appreciate it.
You're very welcome.
Thank you, Tony.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine, for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.